Welcome to the funnel effect. Today, we're doing a deep dive into something pretty significant, a huge piece of medical guidance, really. It's the new 2025 AHAC and MAPASUM Axian Haskim Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults. Phew, that's a mouthful. This thing was led by William Schuyler Jones and Sadia S. Khan, but there were dozens of contributors. It's basically a fundamental rethink of how we tackle hypertension.
It really is. And it's not just, a medical paper. It's more like a public health strategy document. I mean, just look at all the organizations involved. The American Heart Association, the College of Cardiology, sure, but also the nurse practitioners, the Geriatric Society, the AMA.
Yeah, everybody's on board.
Exactly.
Well,
it tells you this is the consensus view, the roadmap for the next, probably the next decade.
And it matters because high blood pressure, hypertension, it's the biggest single modifiable risk factor we have. It links to almost everything bad: cardiovascular disease, stroke, heart failure.
Cognitive decline, dementia, chronic kidney disease. The list goes on.
Right. So our mission today is to kind of cut through the 400 plus pages, all the dense data and jargon. We want to pull out the critical changes, the stuff that might surprise you, and the really actionable information you need to know, moving beyond just the basics.
And maybe the best place to start is with the single biggest takeaway, the anchor for this whole guideline, really. For almost every adult, the main blood pressure treatment goal is now set firmly at less than 130 over 80 millimeters of mercury.
Okay, hold on. Less than 138/80. That feels quite aggressive compared to maybe older guidelines that had different targets for different people. Is it really almost universal now? What's the thinking behind setting that bar?
It is nearly universal, yes.
Yeah.
And the justification, it really comes from the totality of the evidence we have now, especially the long-term results from big trials like SPRINT, the systolic blood pressure intervention trial.
SPRINT, right. I remember that one.
Yeah, SPRINT basically showed that getting systolic pressure down below 120 compared to the older standard of below 140 significantly cut cardiovascular events and, importantly, death from any cause.
Without causing too many problems like fainting or dizziness.
Well, not excessively if the protocol was followed carefully. There was a slight increase in things like low blood pressure symptoms or syncope, but the overall benefit in preventing major events like heart attacks, strokes, and death was considered much greater. So the Guideline Committee looked at all that and landed on 30/80 as the optimal target. It seems to give the most protection against CVD, stroke, and cognitive decline for the broadest group,
Okay.
The only real exceptions are maybe people with a very limited lifespan or specific situations like certain types of institutional care or pregnancy, which we'll get to.
That makes sense. It's about maximizing that evidence-based protection. Now, as we go through this, we're going to mention things like COR1A or COR3 harm. Can you just quickly decode that for folks who might not live in the clinical trial world?
Sure, absolutely. So COR is the class of recommendation. Think of it like a grade for how strongly something is recommended.
Like A, B, C.
Sort of, yeah. COR1 basically means definitely do this. The benefit clearly outweighs the risk, and it's backed by good evidence. COR2A is more like it's reasonable to do this. Benefit still likely outweighs risk. Then you get to COR3, which is don't do this. It could be COR3. No benefit, meaning it just doesn't help. Or worse, COR3. Harm, meaning it could actually hurt the patient.
And the A in COR1A.
Right. The letter refers to the level of evidence. A means it's based on high-quality evidence, usually from multiple randomized controlled trials. That's the strongest level of certainty we generally have in medicine. So COR1A is a very strong recommendation.
Got it. Okay, let's dive into part one, defining the problem, classification, and risk.
Right. So to even aim for that 30/30/80 target, we need clear definitions based on blood pressure readings taken in the office or clinic. The guidelines stick with a pretty clear 4-category system. It's the foundation.
Okay, walk us through the 4 steps.
First up, normal blood pressure. That's simple. Systolic less than 120 and diastolic less than 80. Both numbers have to be below.
Easy enough.
Second, you've got elevated blood pressure. This is sort of the warning zone. Systolic is between 120 and 129, but then this is key, the diastolic is still healthy, less than 80.
So just the top number is creeping up.
Exactly. And this category is a really strong signal that lifestyle changes are needed, like right now, to stop it from progressing to actual hypertension.
Okay, then what?
Third is stage 1 hypertension. That's when the systolic is 130 to 139 or the diastolic is 80 to 89. Notice the or, if either number falls in that range, you're in stage 1.
And stage 2?
Stage 2 hypertension is anything 140 or higher for the systolic or 90 or higher for the diastolic. And a crucial point, If your reading puts you in two different categories, say, you measure 135 over 75.
So systolic is stage 1, but diastolic is normal.
Right. In that case, you always classify based on the higher category. So 135/75 counts as stage 1 hypertension.
Okay, that classification is the starting point. But you mentioned a big change in how we decide what to do about it, moving away from older risk calculators.
Yes, this is really important. The guidelines are making a strong push away from the older risk models, specifically the pooled cohort equations, the PCEs.
Why the change? Weren't the PCEs standard for years?
They were, but recent analysis show they have some significant flaws, especially when used in today's diverse U.S. population. The big issue is that they tend to overpredict cardiovascular risk.
Overpredict? By how much?
In some studies, by as much as double. Think about what that means. If you overestimate someone's risk, you might end up putting them on lifelong medication with all the costs and potential side effects when they weren't actually at that high a level of risk to begin with.
Wow, okay, that's a big deal. So what's the replacement?
The strong recommendation is to shift to the new PREVENT equations. PREVENT stands for predicting risk of CVD events.
And why is prevent better?
It's all about better calibration. It was developed using more contemporary data and includes some updated factors like kidney function metrics and even certain social determinants of health, which we know influence risk.
Better calibration means it more accurately reflects the actual risk in people today.
Exactly. The validation studies show PREVENT performs really well across different racial and ethnic groups: white, black, Hispanic, Asian adults. So it allows doctors to focus treatment on those who are genuinely at higher risk and will benefit most without overtreating people whose actual risk is lower.
So you classify the BP category, then you calculate the prevent score. What's the risk score number that triggers starting medication, besides lifestyle changes, for someone without existing heart disease?
The key definition is increased risk, and the threshold for that is a 10-year risk of developing cardiovascular disease of 7.5% or higher, according to PREVENT.
So 7.5% is the line in the sand.
Pretty much. If you're at 7.5% or above and your office blood pressure is 130 over 80 or higher, the evidence suggests medication is likely beneficial, alongside lifestyle efforts. If your risk is below 7.5%, the primary focus is really doubling down on lifestyle first. Medication might only be considered if the BP later hits that stage 2 level, 140 over 90 or higher.
Okay, that risk stratification is crucial. Let's move to part 2, accurate detection and monitoring. Because none of this matters if the initial reading is wrong.
Absolutely. Garbage in, garbage out, as they say. The guidelines hammer this point home. You have to use standardized protocols for measuring BP in the office. It's non-negotiable.
And this is where things often fall down in busy clinics, right?
Unfortunately, yes. The guidelines detail it clearly. The patient needs to rest quietly for 5 minutes first. They need to be sitting correctly, feet flat on the floor, back supported, arm at heart level, no crossed legs, and absolutely no talking during the measurement itself.
No chatting with the nurse or doctor?
None. And you need to take at least 2 readings a minute or so apart and average them. Little errors in technique, like using the wrong cuff size or not having the patient rest, can easily push someone into a higher category falsely.
We're also seeing a bit of a shift in the method of measurement, away from the old manual cuff and stethoscope.
That's right. The traditional way, auscultation, is still fine. But the guidelines now say it's reasonable, that COR2A, to actually prefer using a validated oscillometric device, one of the automated machines.
Why the preference for the automated cuff? Seems less personal.
It's mainly about reducing observer error. With the manual method, things like the listener's hearing, how fast they deflate the cuff, or even just rounding numbers, up or down digit preference, can introduce variability. A good, validated, automated device follows a strict protocol every time, which can lead to more consistent and potentially more accurate readings, provided, of course, that the device itself is properly validated.
But the guidelines seem to put even more weight on getting readings outside the clinic, don't they?
Oh, absolutely. The highest level of evidence, COR1A, supports using out-of-office monitoring to confirm a hypertension diagnosis and also to track how well treatment is working. This means either ambulatory blood pressure monitoring, ABPM, or home blood pressure monitoring, HBPM.
Let's break those down. What's ABPM?
ABPM is still considered the gold standard, really. It involves wearing a cuff that automatically inflates and takes readings every 15-30 minutes over a full 24-hour period while you go about your normal day and night.
So it gives you the whole picture.
Exactly. You get the average 24-hour BP, the average daytime BP, and critically, the average nighttime BP. And that nighttime reading is actually a stronger predictor of cardiovascular risk than the daytime one.
And ABPM tells you about dipping too, right? What's
Uh,
that?
Right. Normally, your blood pressure should drop or dip
Uh,
by about 10 to 20% while you sleep. ADPM can tell us if someone is a non-dipper, their BP doesn't drop enough,
mm.
or even a reverse dipper or riser, their BP actually goes up at night. Those patterns are linked to significantly higher risks for stroke and organ damage. You could only really catch that with ABPM.
Okay, so ABPM is great for diagnosis. What about HBPM, just using a home machine?
HBPM, whole monitoring, is highly recommended, especially for tracking how well medication adjustments are working for titration. But there's a really important nuance here.
What's that?
The guidelines stress that HBPM works best when it's combined with co-interventions. Just giving someone a machine and telling them to use it isn't nearly as effective as pairing it with things like telehealth support, pharmacist consultations, regular feedback, or specific patient education. Used alone, its impact is much less significant.
Makes sense. Context matters. Now, if people are taking readings at home or with ABPM, those numbers tend to be lower than office readings. How do we translate between them?
The guidelines provide specific thresholds. For example, an office reading of 1490, which is stage 2, corresponds roughly to an average home reading or daytime ABPM reading of 13585. The clinic environment itself can cause a bit of a stress response, the white coat effect.
Ah, yes.
The-
And that brings us to diagnosing those tricky situations where office and home readings don't match up.
Exactly. Comparing office and out-of-office readings helps us identify 4 key patterns. The most famous is white coat hypertension. High BP in the clinic, but totally normal readings at home or on ABPM.
So it's just clinic anxiety.
Pretty much. And the guidelines are clear. If someone's office BP is in that 130-159 systolic or 80-99 diastolic range, you must use out-of-office monitoring to rule out white coat hypertension before starting them on lifelong medication.
That prevents unnecessary treatment. What about the opposite scenario?
That's masked hypertension. This is when the BP looks fine in the clinic, maybe less than 1380, but it's actually high when measured at home or over 24 hours.
That sounds dangerous because it could be
It's
missed.
very dangerous. Masked hypertension carries a significantly higher risk of cardiovascular events, sometimes even higher than sustained hypertension, precisely because it often goes undetected and untreated. Finding it requires out-of-office monitoring, and it usually means treatment needs to be started or intensified, even if the office numbers look okay.
Okay, now for a really critical point, especially with all the tech wearables out there, smartwatches, rings, apps claiming to measure BP. What do the guidelines say about cuffless devices?
This is a huge warning signal. It's a class 3. No benefit recommendation. Basically, a strong do not use. The guidelines state that current cuffless BP devices, anything trying to measure BP without an actual inflatable cuff, are not recommended for diagnosing or managing hypertension.
Not recommended at all. That's a pretty strong statement against a whole category of technology. Why such a hard line?
There are 2 main reasons. First, there's a serious lack of standardized, rigorous validation. These devices haven't been proven accurate compared to standard cuff methods across a wide range of people who need monitoring different ages, body sizes, underlying conditions. They might seem okay for one person, but be way off for another.
And the second reason?
It's the technology itself. They use different methods. Some estimate BP from pulse wave velocity, others use optical sensors, like on smartwatches. These indirect methods can have substantial errors in estimating the actual pressure. Imagine a cuffless device underestimating someone's BP, especially if they have masked hypertension.
They wouldn't get treated.
Exactly. They lose that chance for early intervention, putting them at real risk. The potential for diagnostic error is just too high right now for these devices to be used for making clinical decisions. Stick to validated cuff-based devices for now, whether automated or manual, in the office or at home.
Okay, that's a very clear message. Let's shift into part 3, management. The guidelines really emphasize lifestyle as the foundation, right?
Absolutely. Pillar 1 is lifestyle and psychosocial approaches. These get strong recommendations, often COR 1 or 2A, because they're fundamental for both preventing high BP and treating it.
And top of the list for diet.
It's got to be a heart-healthy eating pattern. And the DAHH, dietary approaches to stop hypertension, is specifically highlighted. In fact, meta-analyses rank DAHH as probably the single most effective lifestyle change for lowering blood pressure.
People hear DHH all the time. What actually is it? What makes it work so well?
Well, DAHH isn't just, eat less salt. It's a whole eating pattern designed to be rich in nutrients that help lower BP, specifically potassium, calcium, and magnesium, while being low in things that raise it.
So lots of fruits.
Vegetables, whole grains, and low-fat dairy, plus nuts, seeds, legumes. And it specifically limits saturated fat, total fat, cholesterol, red meat, and sugary drinks. It's the combination, the synergy of all those components that seems to relax blood vessels and lower pressure.
And that connects directly to sodium and potassium. What are the specific targets?
For sodium, the general target is less than 2,300 milligrams per day, but the ideal target, especially for people who already have hypertension, is even lower, less than 1,500 milligrams per day. That's quite a reduction for most people.
Very tough to achieve with processed foods.
Extremely tough. But every bit helps, and combining sodium reduction with DHH or weight loss gives you an additive effect.
And I saw something interesting about using potassium-based salt substitutes.
Yes, that's a useful finding, COR2A. Using salt substitutes that replace some of the sodium chloride with potassium chloride can actually lower systolic BP by a noticeable amount, maybe 5 to 7 millimeters of mercury on average.
Wow, that's like a low-dose medication.
It can be, yeah. And this is but you have to be cautious. You need to monitor potassium levels, especially in people with advanced kidney disease or those already taking medications that can raise potassium, like ACE inhibitors or ARBs. Too much potassium can be dangerous in those situations.
Good point. Okay, beyond diet, what about weight?
Weight management is crucial. The recommendation is for anyone overweight or obese to aim for at least a 5% reduction in body weight, and the guideline quantifies the effect. You get roughly a 1 millimeter of mercury drop in both systolic and diastolic BP for every 1 kilogram. That's about 2.2 pounds lost.
So losing, say, 22 pounds could mean a 10-point drop in BP.
Approximately, yes. For someone in stage 1, that could potentially be enough to get them below the threshold for needing medication. It's powerful.
And physical activity. We always hear about aerobic exercise.
Yep, the standard recommendation is still at least 150 minutes of moderate intensity aerobic activity per week. Things like brisk walking, cycling, swimming.
But I think the analysis in these guidelines found something surprising about other types of exercise being even more effective.
That was a fascinating finding. When they pooled the data on different structured exercise types, isometric resistance training actually showed the largest average blood pressure reduction.
Isometric, like planks or wall sits, or those hand grip things.
Exactly. Static holds, contracting muscles without changing the joint angle. The average reduction seen was around 8 points systolic and 4 points diastolic.
8/4, that's huge. How does just squeezing something lower BP long term?
The theory is that during the static hold, you temporarily restrict blood flow in that muscle. Then when you release, there's a significant rush of blood flow, a post-exercise vasodilation. Doing this repeatedly seems to improve the overall health and function of the blood vessel, lining the endothelium, leading to lower resting BP over time. It's a really potent, often overlooked strategy that doesn't require fancy equipment.
Very interesting. What about stress reduction? Does meditation actually help?
There's moderate evidence for it, yeah, COR2A2B. It's seen as a helpful addition, not a replacement for the core stuff like diet and exercise.
Yeah.
The guidelines mention transcendental meditation, showing average drops of about 52 mmHg, and structured breathing control exercises, showing maybe 53 mmHg reduction.
So helpful, but not as big an impact as DHH or isometric exercise.
Right. But for some people, especially if stress is a major trigger for their high BP, these techniques can be a really valuable part of the overall plan.
Okay, that's pillar 1, lifestyle. Now, pillar 2, when do we actually start medication alongside all this?
The guidelines lay out 2 main pathways, really, based on the patient's risk profile.
Let's simplify those. Path 1 is for
Path 1 is for people needing secondary prevention. This means they already have clinical cardiovascular disease like a past heart attack or stroke, or they have diabetes or chronic kidney disease, or they fall into that high-risk category based on the PREVENT score, that 7.5% or higher 10-year risk.
Okay, so higher risk individuals.
Exactly. For this group, if their blood pressure is 130/80 or higher, you initiate drug therapy along with lifestyle changes. The goal is aggressive protection because their vascular system is already compromised or at high risk.
And path 2.
Path 2 is for primary prevention in people considered at lower risk. So their PREVENT score is less than 7.5%, and they don't have diabetes or CKD or existing CVD. For this group, the recommendation is to really focus on intensive lifestyle changes first. You typically only start medication if their BP reaches 140/90 or higher, usually after giving lifestyle changes a solid try, maybe 3 to 6 months, to see if they can get below the 100 to 30/80 target without drugs.
Got it. So once the decision is made to medicate, what are the go-to first-line drug classes?
There are 4 main classes recommended as first-line options, all with strong CR1A evidence. They are thiazide-type diuretics, long-acting dihydropyridine calcium channel blockers, CCBs, ACE inhibitors, ACI, or ARBs, angiotensin receptor blockers.
You said thiazide-type diuretics. Is there a specific reason for that wording, not just any thiazide?
That's a key nuance, yes. While the class technically includes the very common hydrochlorothiazide, or HCTZ, the guidelines point out that the evidence for better outcomes and longer-lasting BP control is actually stronger for the thiazide-like diuretics, specifically chlorthalidone and indapamide.
Why are they preferred over HCTZ?
They generally have a much longer duration of action, a longer half-life. This means they provide smoother, more consistent 24-hour blood pressure control, which might be better at preventing those dangerous early morning BP surges. So while HCTZ is okay, many experts now prefer chlorthalidone or indapamide when starting a diuretic.
Makes sense. Now, adherence is a huge issue with lifelong meds. How do the guidelines address that?
They strongly recommend using single-pill combinations, SPCs, whenever possible. This gets a COR1BR recommendation.
So one pill containing two different drugs?
Exactly. The evidence is really clear. The more pills someone has to take each day, the less likely they are to take them all correctly. Adherence drops off sharply. If someone needs 2 drugs to reach their BP goal, which is common, especially if their starting BP is way above target, like 20-point systolic or 10 points diastolic over goal, giving them one combination pill significantly improves adherence and ultimately leads to better BP control and fewer heart attacks and strokes compared to giving them 2 separate pills.
Simpler is better. Before we leave medications, there's a critical safety warning about combining certain types.
Yes, absolutely crucial. Affirm Class 3. Harm recommendation. You should never use an ACE inhibitor, an ARB, and more a direct renin inhibitor together in the same patient.
So no doubling or tripling up on drugs that block the renin-angiotensin system.
Correct. Combining these drugs doesn't really give you much extra BP lowering, but it significantly increases the risk of serious side effects like dangerously high potassium levels, hyperkalemia, and acute kidney injury. It's a combination to avoid.
Good to know. Let's move into part 4. Managing specific situations and comorbidities. What about patients with kidney disease or diabetes?
Right. For patients who have chronic kidney disease, CKD, or type 2 diabetes, T2D, the blood pressure target remains that same aggressive goal, less than 130 systolic and less than 80 diastolic. But the choice of medication is often tailored for organ protection.
And that usually means using one of those RAAS inhibitors we just talked about, right? The ACEs or ARBs?
Exactly. If someone has CKD, which is usually defined as an estimated glomerular filtration rate, eGFR, below 60, or if they have significant protein, albumin, in their urine, albuminuria of 30 milligrams, then using an ACE inhibitor or an ARB is specifically recommended.
But not both together.
Never both together. The reason for using one of them is not just to lower the overall body blood pressure, but also because these drugs help protect the kidneys themselves by reducing the pressure inside the kidney's filtering units, the glomeruli. This can slow down the progression of kidney disease over time.
Okay, but sometimes when you start these drugs, the kidney function numbers seem to get worse initially. That famous eGFR dip. Can you explain what's actually happening there? It scares people.
It does, and it's really important to understand. When you start an ACE inhibitor or an ARB, it causes the small blood vessel leaving the kidney filter, the efferent arteriole, to relax and widen. This lowers the pressure inside the filter.
Which is good for the long run.
Right. It reduces the strain. But the immediate effect of lowering that pressure can be a small temporary drop in the calculated kidney function, the eGFR. This dip can be up to about 30% from their baseline reading.
So a drop is expected?
A modest drop, yes, it's often expected, and even indicates the drug is working as intended to reduce glomerular pressure. The guidelines are very clear. If the eGFR drops but then stabilizes within that 30% range, you should not stop the medication. It's actually associated with better long-term kidney preservation. You only need to reconsider the dose or stop the drug if the eGFR keeps falling beyond that 30% mark or if other issues arise.
That's a critical clarification. Okay, shifting focus to the brain. How does BP management affect cognition and stroke? The goal for preventing cognitive decline seems quite aggressive.
It is. The guidelines give a strong CUR-1 recommendation for targeting a systolic blood pressure of less than 130 millimeter Hg, specifically for the purpose of preventing mild cognitive impairment and dementia.
Based on trials like SprintMind.
Exactly. The long-term follow-up from SPRINT showed that intensive BP lowering significantly reduced the chances of developing cognitive problems later on. It seems to protect the small blood vessels in the brain.
Now, what about acute stroke situations? This gets really tricky. Let's start with a bleeding stroke, intracerebral hemorrhage, ICH.
Okay, for someone having an acute bleed in the brain, if their initial systolic pressure is really high, say between 150 and 220, the evidence suggests that carefully lowering it into a target range of 130 to less than 140 millimeter Hg is generally beneficial for their outcome.
But there's a major warning here too, right?
Yes, a very important COR3 harm warning. Lowering the BP too aggressively, or aiming for below 140 immediately, or letting the pressure swing up and down wildly label a control can actually make things worse. The key is smooth, controlled lowering into that specific 130 to 140 zone.
Okay, what about the more common type of stroke, an ischemic stroke, where a vessel is blocked, especially after they've had treatment to open it up?
This is where the guidance is perhaps most counterintuitive, and again, carries a COR3. Harm warning. After a patient has successfully had a clot removed or dissolved, endovascular therapy or thrombolysis, the brain tissue around the damaged area is very vulnerable and needs good blood flow, which often requires slightly higher pressure initially.
So lowering the BT too much is bad.
Yes, the guidelines state that lowering the systolic BP to less than 140 millimeter Hg during the first 24 to 72 hours after successful reperfusion can actually worsen the patient's long-term functional outcome. You need to exercise restraint in BP lowering during that critical early recovery period.
Wow, okay. That's vital to know. Let's touch on hypertension during pregnancy. This is always a high-stakes situation.
Extremely high stakes. We call these hypertensive disorders of pregnancy, or HDP. The real emergency is severe hypertension.
What's the definition of severe and how quickly do you need to act?
Severe hypertension in pregnancy is defined as a systolic pressure of 160 or higher, or a diastolic of 110 or higher that's confirmed on a repeat measurement soon after. When that happens, it's a COR1 recommendation that antihypertensive medication must be given and given quickly within 30 to 60 minutes
Why the extreme urgency?
to prevent catastrophic complications for the mother, especially things like eclampsia, seizures, or, crucially, hemorrhagic stroke. Stroke is a leading cause of maternal death in this situation. Prompt treatment saves lives.
And are there specific BP meds that absolutely should not be used in pregnancy?
Yes, another critical COR3, harm. Pregnant individuals must not be treated with ACE inhibitors, ARBs, direct renin inhibitors like aliskiren, nitroprusside, or a specific beta blocker called atenolol. All of these carry significant risks of harm to the developing fetus.
So what are the preferred drugs?
The preferred first-line agents are generally labetalol, which is a combined alpha and beta blocker, and long-acting nifedipine, a calcium channel blocker.
Okay, good to know. Let's move to part 5. Advanced strategies for when the basics aren't enough, starting with resistant hypertension. How is that defined?
Right, resistant hypertension, or RH. It's defined in two ways. Either the blood pressure stays above the target, usually 380, even though the patient is taking 3 different antihypertensive medications, one of which must be a diuretic at optimal doses, or it's when the BP is controlled, but it requires the patient to take 4 or more different medications.
So hard to control BP. What's the very first step when you suspect RH?
The absolute first step is always to rule out pseudo-resistance.
Meaning it looks resistant, but it isn't really.
Exactly. Before you label someone as truly resistant and start complex workups, you have to make sure the readings are accurate. Check the measurement technique again. You need to rule out the white coat effect using out-of-office monitoring. And, probably the most common reason, you need to check for medication non-adherence. Are they actually taking all the pills as prescribed?
That takes careful conversation.
It really does. You often need multiple approaches, pill counts, pharmacy records, sometimes even blood or urine tests to assess adherence properly. Because if they're not taking the meds, adding more won't help.
Okay, let's say you've ruled out pseudo-resistance. It's genuine RH. What's next?
Then you need to start looking seriously for secondary causes of hypertension, an underlying condition driving the high BP, and the guidelines put a huge emphasis on screening for one specific condition.
Which is?
Primary aldosteronism, PA. This is now a COR1 recommendation screen for PA in patients with resistant hypertension. PA is when the adrenal glands produce too much aldosterone, a hormone that makes the body retain salt and water and drives up BP.
And the big change here is who to screen, right? Didn't we used to only screen people with low potassium levels?
That's the crucial update. The guidelines explicitly say to screen for PA regardless of whether the patient has hypokalemia, low potassium.
Why the change? I thought low potassium was a classic sign.
It was considered classic, but it turns out it's not that common. Only about 20% to maybe 50% of people with PA actually have spontaneous hypokalemia, The majority have normal potassium levels.
So we were missing most cases by only screening based on potassium.
Exactly. PA is actually much more common than we thought, maybe causing up to 10% of all hypertension and possibly 20% or more of resistant cases. If you only screen the ones with low potassium, you miss diagnosing and appropriately treating the vast majority who could really benefit from targeted therapy, like aldosterone blockers.
That's a huge practice change.
Yeah.
So if someone has true RH, they're on 3 drugs, including a diuretic, PA has been ruled out or treated. What's generally the next best pharmacological step?
If they're already on an optimal combination, usually an ACI or ARB, plus a calcium channel blocker, plus a thiazide-like diuretic, the recommended fourth drug to add is a mineralocorticoid receptor antagonist, MRA. The most common one is spironolactone.
Why spironolactone specifically?
It gets a COR1BR recommendation because trials like Pathway 2 showed that adding spironolactone was significantly more effective at lowering BP in resistant patients compared to adding other types of drugs like beta blockers or alpha blockers. It often gives you that extra 6, 8, sometimes 10 millimole Hg drop needed to get to goal, likely by blocking residual aldosterone effects.
Okay. Now, the guidelines also mention a non-drug procedural option, renal denervation.
Yes, renal denervation or RDN. This involves using a catheter to deliver energy, usually radiofrequency or ultrasound, to nerves surrounding the renal arteries, aiming to reduce sympathetic nerve activity that can drive up BP.
But it's not a first-line thing, is it? Who is it for?
Definitely not first line. It's considered an adjunct therapy, something to consider in addition to medications for a very select group of patients. The criteria are pretty strict. They need to have office BP in the range of 140-180 systolic and diastolic or 90, despite being on optimal medical therapy, or maybe they have documented intolerance or side effects that prevent adding more drugs. And they need to have decent kidney function, generally an eGFR of 40 or higher.
And it's not just about the numbers, there are process requirements too.
Absolutely critical. Any patient being considered for RDN must be evaluated by a multidisciplinary team that has expertise in managing resistant hypertension. It's not a decision for one doctor alone. And, importantly, it requires shared decision-making, COR1 CEO.
Meaning the patient has to be fully informed and involved.
Totally. They need to understand the potential, often modest, BP-lowering benefit versus the procedural risks. While generally safe, there are risks like vessel injury and, importantly, a small but real ongoing risk, maybe 0.2% per year, of developing renal artery stenosis narrowing later on, which requires long-term surveillance imaging. It's a commitment.
Okay. Finally, the guidelines really zoom out to look at the bigger picture, the system level. Improving BP control isn't just about individual patients and doctors.
Right. They emphasize tackling structural barriers, things related to social determinants of health, SDOH. Access to healthy food, safe places to exercise, transportation to appointments, stable housing. These things massively impact BP control.
And how do they recommend addressing these system issues?
A key strategy is team-based care, COR1BR. Using multidisciplinary teams, doctors working alongside pharmacists, nurses, dietitians, community health workers, social workers, is much more effective at achieving and sustaining BP control than the traditional doctor-only model. Pharmacists in particular are highlighted for their role in comprehensive medication management.
And technology plays a role in supporting these teams.
Yes, integrating health information technology, HIT, is crucial. Things like using electronic health record registries to identify and track patients who aren't at goal, and using telehealth, whether it's video visits or asynchronous communication like secure messaging or remote monitoring, coupled with home blood pressure monitoring, HBPM.
Especially when combined with those co-interventions you mentioned earlier.
Exactly. When you bundle telehealth, HBPM, and co-interventions like pharmacist support or nurse coaching, the evidence shows it's very effective, COR1BR, at improving BP control rates, medication adherence, and patient self-management. It helps bridge the gaps in care.
Okay, this has been an incredibly detailed look at a really comprehensive guideline. Let's try to boil down the absolute key takeaways. First, that universal goal. For almost everyone, the target is less than 130/80.
Yeah.
Second, accurate measurement is non-negotiable. Rely heavily on out-of-office monitoring, ABPM or HBPM with support. And remember that strong warning, cuffless devices are not ready for clinical prime time.
Definitely. Stick to validating cuffs.
Third, lifestyle is powerful. The DASH diet leads the pack, but don't underestimate the surprising impact of isometric resistance training.
A great actionable point.
Fourth, crucial updates for specific groups. Aim for SBP 130 to help prevent dementia. In acute ICH, target 130 to 140 carefully. In acute ischemic stroke post-reperfusion, avoid lowering SBP 140 initially. And in pregnancy, severe hypertension needs treatment within 30 to 60 minutes, avoiding specific harmful drugs.
Lots of important nuances there.
And fifth, for resistant hypertension, screen for primary aldosteronism even if potassium is normal. Consider spironolactone as the go-to fourth drug, and remember that renal denervation is an adjunct option requiring a multidisciplinary team and shared decision-making.
You got it. That covers the big shifts. And really, these guidelines, they represent our best collective understanding right now. They're meant to be a practical tool to improve the quality of care, to align treatment with what's best for patients based on solid evidence. But, the knowledge itself isn't enough. It has to be understood and actually applied consistently.
Right. And speaking of application, you touched on this earlier, the immense challenge of sodium reduction. The guidelines point out most of our sodium comes from processed and restaurant foods. Individual effort is important, but maybe not enough on its own.
It raises a really fundamental question, doesn't it? We know from public health experience that population-wide strategies, things like gradually reformulating foods to contain less sodium, could potentially prevent vastly more heart attacks and strokes than just relying on individual willpower against a food environment saturated with salt.
So the final thought for our listeners to maybe ponder is this. We have these incredibly detailed clinical guidelines telling us what individuals and doctors should do. But how do we, as a society, bridge that gap? How do we connect the push for individual lifestyle change with the potentially much more impactful, broad food policy changes that might be necessary to actually achieve the population-level sodium reduction goals laid out in these critical guidelines?
That's the multi-billion-dollar public health question, isn't it? A real challenge for policymakers, the food industry, and all of us.
Indeed. Something to think about long after this deep dive ends. Thank you for watching The Funnel Effect.